I'm Dr. James Patrick Murphy, and I want to thank Representative Moser for inviting me here today to discuss the buprenorphine regulation briefly and how we can save lives together. I am a anesthesiologist. I'm a pain specialist. I'm an addiction medicine specialist. I'm a professor at the University of Louisville School of Medicine. I am the past president of the Kentucky Society of Addiction Medicine. I am currently on the board of directors of the American Society of Addiction Medicine. And I am here on behalf of my colleagues and on behalf of the thousands of Kentuckians who are dying and who are living and struggling with addiction and need life-saving care. And I have some good news and I have some bad news. The bad news is that we have a regulation in this state, the buprenorphine regulation, that is a barrier to care to this life-saving medication. It is outdated. It is not evidence-based. It is not consistent with the standard of care. It is harmful to Kentuckians. The good news is it's unnecessary, and we can repeal it, and we should repeal this regulation. I'm going to give you 6 reasons why. The first reason is what we're dealing with here is a crisis that's unparalleled. Since 2000, 26,000 Kentuckians have lost their lives, mostly young people, in the prime of their life. Rupp Arena holds, 23,000? Imagine that, 26,000 deaths. We lose approximately 2,000 people to this disease every year. The last 4 years have been the most deadly in Kentucky's history, although we've had a slight drop in overdoses in the past year. I think a 9.8% drop. That's the overall overdose death rate drop, which is great. We should welcome that. However, not everybody saw a drop. Our black population in Kentucky, their overdose rate actually rose. And we do know that whenever there's a barrier to access to care, it disproportionately affects the minoritized communities. So this crisis is ongoing. It's come down a little bit, mostly because we believe naloxone has been more widely distributed. And that's great. We welcome that. But Narcan, it reverses the effects of an overdose. It does nothing to treat the actual disease of addiction. Nothing. It does preserve life, so you can treat them. What treats them is things like medication, and buprenorphine is the most effective medication we have for treating opioid use disorder and preventing overdoses. Okay. Reason number 2, it is a disease. Addiction is not a moral failing. It's not a choice everyone makes. It's a disease. It's like diabetes, for example, or lung cancer we just heard about. It's a disease, and diseases usually involve an organ that is damaged, and there's symptoms, and there's usually treatments. Well, in this case of addiction, it's a part of the brain called the midbrain. It's a subconscious part of the brain that controls some of these urges that we have, actually urges that are important to keep our lives safe and healthy. For example, thirst. Those of you who have been sitting here for a while and have not had your water, maybe you're getting thirsty. Well, imagine in the summertime, you're sitting out there in the hot sun, very thirsty. It's uncomfortable, and you finally get that drink of water. It feels good. It tastes good. Well, that's part of your brain doing that. That's the midbrain. That's the reward center in your brain. And that's the part of the brain that is damaged in addiction. So it is a medical illness. Number 3, we have treatment for this. We have a very effective treatment. Okay? Here's how it works. Buprenorphine is not a powerful opioid. It's a partial opioid. It has what we call a ceiling effect. It's not risk-free, but it's not methadone, and it's not some of the other opioids. People can take it once a day. It covers that part of the brain, treats it kind of like a diabetic taking insulin, and it calms down that part of the brain so that people can think more clearly, can get the care they need, can function in their lives. It's incredibly effective medication. And that's reason number 4. A month ago, Dr. Nora Valco, who is the director of NIDA, she's the top addiction scientist in the country, if not the world. She was at the University of Louisville. She gave a keynote address, and we gave her an award. She's a hero. She has said that we could lower the overdose death rate in this country if we had universal access to buprenorphine. She said we could lower it by 50%. We could cut it in half. Think about that for a second. I just told you 2,000 people die every year. And this medication, just this medication could cut that in half if we had universal access to it. And the reason number 4 is that we have barriers to that access. And this regulation is one of those barriers. And the barriers to people getting this medication are economic, they are stigma related, and fear related. And this regulation contributes to all of those. The regulation is not evidence-based. It is not the standard of care. It requires things that are not necessary for patients to get this medication. And they're expensive. Number 2, just the mere presence of this regulation is stigmatizing. Think about it. I mentioned diabetes. We have lung cancer. Other diseases, hypertension. Think about it. There are no separate regulations for these diseases. So having a separate regulation stigmatizes it. Why is it so different? Why are these people treated differently? Why do we look at them differently? And the third reason is fear. The existence of a regulation that doctors have to follow that they don't really always understand. I mean, we read medical textbooks, we look at charts, we do research. We don't really make these regulations or even know how to follow them sometimes. But if we stray, we're fearful that we'll lose our license and our livelihood and our ability to care for people. That is real fear, and that is one of the major reasons why there are so few doctors willing to prescribe this medicine in Kentucky. Again, a medication that Dr. Valco said could lower the overdose death rate by 50%. Number 5.
Dr. Murphy, you're at about 8 minutes, so if you can maybe get to the part of the regulation that you are seeking to change.
Yes, I will.
Okay.
Thank you. Number 5, what happens here is that if we do away with this regulation, it's still a controlled substance. It's still a Schedule III controlled substance. It'll still be regulated. It's not going to be the Wild West. It'll still be regulated. And there's also already a regulation in place that will that will take care of all controlled substances, and buprenorphine would be controlled by this regulation as well. It's 201 KAR 9260. It would still be a controlled regulation, but not a specific buprenorphine regulation. Why is Kentucky one of the few states that has a buprenorphine-specific regulation now? We are an outlier. The regulation is outdated. It is unfixable. It is harmful and needs to be repealed. And number 6, the last reason I'll give you, there are 6 people that will die today of an overdose. All 6 of those deaths are preventable. They're all people, and there's going to be 6 tomorrow. On the average, we lose 6 people. We need to do something about that. Repealing this regulation would help do that. And the last metaphor I'll give you, and this will be brief. I mentioned thirst. Well, and those of you who may like to travel have been to, maybe Death Valley before. It's a beautiful place, but it used to be a sea. It used to be an ocean. And it's no longer an ocean. Now it's a desert. There's sand and there's salt there. Well, imagine you're going through that, and you're just literally dying of thirst in the hot sun. You're not concerned about, nor should we be concerned about, putting a patch on a hole in a boat. What these people need, what the person needs is water. They need nourishment. They need care. Buprenorphine is like water to this disease. This regulation is a barrier to that care. You can do something about it. Please help us do something about it so people can get the care they need, this life-saving care. Thank you.